Right, let's kick off. Welcome to today's webinar. Today our topic, of course, mastering high-level disinfection. And today a very important focus. We use high-level disinfectants, of course, all over the hospital setting, perhaps focusing today on the operating room, but certainly something that is applicable throughout. Today's webinar is kindly brought to you by SAFMed. SAFMed is your solutions partner and has been so for over 35 years now, both in the CSSD, the operating room, and in fact in the GI unit as well. Welcome to today's session. So what will we cover today? High-level disinfection is a very important concept and a very important topic to all of us, I believe. We'll start off by covering some of the terms and the definitions that are relevant when it comes to high-level disinfection. We'll remind ourselves a little more on Spaulding's classification, a topic we know quite well, but of course important that we understand it clearly. We'll review the microbial activity of high-level disinfectants. We'll cover the correct use of high-level disinfectants, and importantly, we'll understand what can go wrong. We will look at a few published papers of incidences where things have gone wrong with high-level disinfectants, and that will be something very important for us to cover as well today. Okay, terminology. An important concept is what is the difference between an antiseptic and a disinfectant. Remember that an antiseptic is used to reduce the microbial levels on skin and live tissues, whereas a disinfectant is a chemical or a combination of chemicals used for disinfection, and it reduces the microbial contamination on surfaces and inanimate objects, so medical devices. Disinfection itself is the process of inactivating viable microorganisms to a level that's been previously specified, and that level is obviously then going to be appropriate for the defined use of that particular product or that particular device. Scarily, of course, we have a multitude of microorganisms that are in our hospitals that potentially can be dangerous and can infect our patients. They include, for example, prions, viruses, bacteria, and fungi. High-level disinfectants, of course, are not going to be effective against prions at all. We know that we have viruses like hepatitis, HIV, coronaviruses maybe, nasty bacteria like Staphylococcus aureus. Staph aureus, of course, can cause skin infections, wound infections, GI infections, respiratory tract infections. E. coli, we know that normally inhabit our gut, but of course can cause diseases of the respiratory tract and affect other areas of the body. Fungi that are around that are terrible include Candida, Candida aureus, Aspergillus. Don't forget TB. All of these things well known to us and that can cause horrible infections of our patients. And of course, the objective is to make sure that we're providing devices and instruments that are safe to use on patients that do not have any of these microorganisms. These microorganisms, as you know, of course, have also become quite resistant to a number of different antibiotics. And in fact, in some cases, they have become resistant to some high-level disinfectants as well. We need to make the decision now every day that we're processing a device that we're about to use on the patient on how we're going to process it. And that decision on whether we're going to use some form of high-level disinfection, whether we're going to just use low-level disinfection, or whether or not we need to sterilize it, we base that on Spaulding's classification. Because there is really a huge big difference between high-level disinfection and, of course, sterilization. The biggest is the distinction that we would use is the sterility assurance level. We'll talk to that a bit more now. Our main focus today is going to be on semi-critical devices. Semi-critical devices, of course, are objects that come into contact with intact mucous membranes or non-intact skin, but that don't really penetrate the blood barrier. Where possible, semi-critical devices actually should be sterilized. If it's really not possible, then or not feasible based on the device itself, at the very minimum, then these devices need to be subjected to high-level disinfection. And of course, the goal there is that we want to destroy all microorganisms and, in all likelihood, not all bacterial spores when you are high-level disinfecting items. In most cases, of course, meticulous physical cleaning is the first step. We follow that by a high-level disinfection. At the end of the day, hopefully that we've, with reasonable assurance, that we've eliminated pathogens to a degree that the device is safe to use on the patient. It's a very nice published paper where they reviewed Spaulding's classification, a very comprehensive review. Spaulding's was, of course, originally proposed in 1957. But what we do know is that a number of things have changed since 1957. And the question is, then, is Spaulding's classification still relevant? Well, they summarize in this paper and they highlight the fact that Spaulding's is certainly still relevant, but maybe it needs to be updated, and we need to address the modern day challenges, because the modern day challenges include the new pathogens, include microbial resistance, and of course we need to take into account now the complexity of the medical devices, the designs that have become incredibly complex, especially, for example, modern endoscopes, for example, and they require a complicated cleaning and complicated disinfection. It's not a simplistic process. Here's an incident that happened in Brazil in 2009, or the paper was published in 2009. It's an epidemic of a post-surgical infection, and this was caused by a Mycobacterium miscelensis, and this was reported in the Journal of Clinical Microbiology. Is this a microorganism we see in the South African context? Yes, it has been seen in South Africa. Outbreaks have been seen, in fact, in beauty clinics. Something that we need to be aware of and something that we could very well find in our hospitals at some point. In this particular outbreak, there were over 1,000 patients, in fact, over 1,051 possible cases. This was all after minimal invasive surgical procedures, the majority of them being laparoscopic. Some of them were orthopedic and knees and joints, but the majority of the cases were actually laparoscopic. The outbreak happened in 63 hospitals across the state of Rio de Janeiro in Brazil. In the end, 197 cases were confirmed to be part of this outbreak. And the outbreak was, in fact, linked to the use of a 2% glutaraldehyde at the time, that was used to disinfect the laparoscopic instruments. You can see on the images over here where sepsis formed, where these abscesses formed, and long after the original case, up to 6 months later, in fact, and they then realized that this particular microorganism had become resistant to this 2% glutaraldehyde. A huge outbreak back in the day when we were still soaking a lot of our ports and our laparoscopic instruments. Hopefully we've moved on and those instruments are now these days being sterilized. Because there's a difference, as we said. When we're sterilizing our devices, of course, we are killing all viable microorganisms, including bacterial spores. When we're using high-level disinfection, we're hoping that if we do it effectively, that we have killed all microorganisms and some bacterial spores. And of course, then we have low and intermediate disinfection. Disinfection is therefore going to be a process that does not necessarily kill all microorganisms, but reduces them to a level that is not harmful to health, a generic description of disinfection. What about the disinfectants themselves? Here are some examples of low and intermediate disinfectants. They include alcohols and halogens like chlorine-based products. They do have antimicrobial effects, some effects. They have negative effects as well, as is common with all chemistries. Alcohols, for example, can be flammable and they can damage some surfaces. They're definitely not effective against bacterial spores. In some cases, people will wipe down bits of equipment. I'm aware of people that will wipe down perhaps camera leads and cables, sometimes in a ward setting or in the operating room as well, using alcohol-based disinfectants. Is that really the best way to go? Chlorine, used commonly. I think perhaps a more common term may be biocide. Chlorine, of course, common in bleach, often used for surface disinfection, effective against bacteria, fungi, viruses, some microbacteria, some cysts even. Of course, it can damage surfaces, especially metals, and has a really, really strong odor. We tend to use it for rapid disinfection and environmental scenarios. Of course, chlorine is commonly found in bleach. Coming to high-level disinfection, available in our country would be products using both aldehydes and perhaps those using hydrogen peroxide or peracetic acid. From the aldehyde sense, I'm sure many of you are familiar that have used high-level disinfection in operating rooms. We used to use 2% glutaraldehyde, and then in the modern days, we moved towards OPA-based products with good antimicrobial effects against bacteria, fungi, viruses, most mycobacteria, and spores. It is toxic. All chemistries are toxic to a degree, can have a strong odor, can be difficult to rinse off, and can stain surfaces, especially OPA. If you leave proteinous material on the product itself, it often turns purple or discolors during the high-level disinfection and can sometimes be difficult to get off. We use high-level disinfection, especially, or aldehydes, especially manually, and often for flexible endoscopes in a manual process. Hydrogen peroxide and peracetic acid sometimes are used separately, so you could have products that contain just hydrogen peroxide or just peracetic acid or combinations thereof. Also have very good antimicrobial efficacy. They can damage surfaces. They may have a strong odor. They can be a little bit problematic if you're using very soft metals, or if, for example, you have instruments and devices where the outer layer of the instrument has started to give way a little bit and you're seeing a little bit of the metal underneath it, the softer metal underneath it. That can be a little bit difficult when it comes to those. And these types of products are used in liquid and in gas form, both for disinfection and sterilization, and are often used these days in automated endoscope washer disinfectors. Most of those we tend to use now, we use hydrogen peroxide and peracetic acid-based products because their efficacy is well known, especially in those automated processes. When we're using a high-level disinfectant, of course, we need to get rid of microorganisms. Whether we're sterilizing or we're disinfecting, the scientists are going to start with the assumption that there are 1 million microorganisms on the device. We use that so that we've got some form of a scientific calculation or measure to work with. Of course, we can express 1 million as 10 to the power of 6. So we're looking at our graph and we're looking at our table over here. We talk about reducing the microorganisms by a log. So we will say that ultimately we want to get 10 to the power of 6, 1 million microorganisms, down to 0 so that it is safe to use on the patient. We want those microorganisms off the device. When we reduce by 1 log, if we're looking at the table now, we've gone from 1 million microorganisms down to 100,000. 2 logs, we're down to 10,000. 3 log, we're down to 1,000. Eventually, at the 6 log reduction, we're looking at 1 microorganism left on the device. That's our scientific principle that we work with. Of course, when we're sterilizing, we use an overkill scenario. And then we don't just ask for a 10 log reduction, we ask for a 12 log reduction. We aim for that. So then we're looking at 10 to the power of -6. So that helps us to remember the difference between sterilization versus high-level disinfection. Sterilization using the overkill method, high-level disinfection, reducing our microorganisms on our devices to a level that hopefully they are not harmful, and hopefully with a 6 log reduction, but possibly a little less than that. As we all know, there are a number of standards that exist, standards for sterilization, standards for high-level disinfection, and of course each country has their own standards. We'll have British standards, we have South African standards, we have American standards, etc., etc. When it comes to high-level disinfectants, we tend to focus on the European standards, and European standards are harmonized standards, so standards that the whole of Europe now adheres to. When a manufacturer provides you with a product, or you're buying a high-level disinfectant, they have to prove to you that it is effective, and they test that product versus various standards. So here are some of the examples. Now, there's a whole multitude of EN standards for disinfectants, and these are some of the examples and what it is that they require. For example, these two test methods, 13727 and 13697, for bacteria are looking for a 5-log reduction. So when somebody comes to you and they say, this is our product, it's really, really good, they need to be able to tell you which standard, exactly which standard they actually tested it to, so that you can understand its efficacy. So for bacteria, in this particular test method, we're looking for a 5-log reduction. For fungicides, fungicidal efficacy in yeast, we are also, in this test methodology, we are looking for a 5-log reduction. And the tests vary slightly. Some are in suspension, some are on surfaces, some will be with clean instrumentation, some will be done with instruments that are dirtied, and how effective it is in the presence of swelling. Here for viruses, we're looking at a 4-log reductions, and for sporicidal activity, so are we getting rid of spores, we're expecting a 4-log reduction. So with this as an example of a laboratory testing, so the manufacturer might say to you, here is our results, and they say to you, we have conformed to the following standard, so then you need to be able to understand what that standard calls for, because then you need to know what you need under your circumstances. Or in some cases, they may actually provide you with the actual results from the laboratory themselves, that you can clearly see exactly how effective the high-level disinfectant is. And you need to be aware of that, because you need to know what microorganisms you have in your hospital settings, what it is you're dealing with, and whether the high-level disinfectant that you are now going to use is going to be effective against the microorganisms that you're coming across. Okay, that's the product itself, that's its microbial efficacy, but how do we use it effectively, and how do we use it responsibly? So going forward, I'll have quite a few images that I've taken in the field under various circumstances, and hopefully they'll help remind us about what we should be doing. If you look at the image on the far right, you can see the volume of lint floating in that particular container, because nobody ever kept the lid on. The image in the middle is that of a flexible scope that was being subjected to high-level disinfection. In this particular incident, the high-level disinfectant was never even put down the biopsy channel, and as you can see, only a portion of the scope was ever submerged in the high-level disinfectant. Very poor practice. In the image on the left over here, we have a staff member who was doing a case that wasn't scrubbed, mind you, and was now removing the items from the high-level disinfectant to put them into sterile water. At least that was accurately done. In that particular instance, not everything was properly submerged. You can see the volume in the tub or the container is actually quite reduced. So effective use of this high-level disinfectant is absolutely important. If we don't use it effectively, we are not going to get that log reduction that the product is meant to be able to give you if we don't do the job correctly. What does it take? What do we have to do to get an effective process? Well, the first thing is that, have we looked at the device and have we understood how we are going to use it? If it is a device that actually needs to go, is a critical device that's going into a sterile part of the body, is going to make contact with blood, it needs to be sterilized, not high-level disinfected. And if you're using high-level disinfection to replace sterilization, why? Is it because you don't have enough equipment? Is it because your list is too fast? Is it because you haven't arranged your circumstances correctly? Because if you're using high-level disinfection when you should be sterilizing, you need to stop and think, what am I doing? Why am I doing this? Very important now is that the device that you're about to put into the high-level disinfectant is thoroughly cleaned with the correct type of detergent. And you know how to thoroughly clean a device. Once you've thoroughly cleaned the device, you need to rinse it thoroughly before you put it into the high-level disinfectant, as well as dry it, remove the residual moisture. If you take the device and it's quite wet and you put it into the high-level disinfectant, by the end of the day, when you do that repeatedly, the high-level disinfectant will be so diluted, it will no longer be effective. To be effective, of course, the high-level disinfectant must make contact with all areas of the instrument or the device itself. Looking at the image in the middle over there, this was a urology list where high-level disinfection was being performed in this metal tub with a very small volume in it. You can see that the instruments and the devices were not properly submerged. They were never properly or fully covered. That's just silly. So important to dismantle the devices that you can. If there are lumens, you need to make sure that the disinfectant is being placed or flushed through the lumen itself, and that the contact time that the device has with the high-level disinfectant is as per the manufacturer's instructions for use. If it says 5 minutes, well, then it takes at least 5 minutes to reduce the microorganisms to that 5 or 6 or 4 log reduction that is required. And you need to soak it for that amount of time. Then we need to thoroughly rinse off the high-level disinfectant because these products are chemistries. They can be toxic. They are toxic to normal tissues. You need to rinse off thoroughly. But what do you rinse off with? Hopefully sterile water. If it is an endoscope, yes, then we tend to use tap water because in that case we are going into mucous membranes, but in all other procedures, sterile water is what we are looking for. And of course, have we followed the instructions for use clearly and carefully? And importantly, did we test the minimum efficacy of the concentration of the high-level disinfectant? As you know, these products should come with some form of test strip, and you should have those test strips on hand. If you're not doing that, if you're not following these basic steps and these basic principles, you will not effectively high-level disinfect a device. The trick to high-level disinfection is that we are often doing it in an area close to the operating room or in the operating room itself. And it's generally something where we're expecting fast turnover. And as a result, we tend to cut corners. Let's be honest, that does happen very often. So not only are we cleaning in an area where we shouldn't be cleaning, we were potentially contaminating scrub basins, anterooms, and the like with all sorts of microorganisms while we're cleaning. We're doing it quickly. And often we're using the wrong products, not necessarily the correct detergents even. Here, the example in the middle is of somebody cleaning a laryngoscope blade that they then soaked in high-level disinfectant for the next case. They used heavy scrub or hand soap, the red soap you're familiar with over there. And you'll note the brush in the lady's hand was in fact the nail brush that the surgeon had just used to clean his hands with. Definitely not correct practice. What about the tub itself or the container itself that the high-level disinfectant is going to be soaked in? The image over there on the right is that same tub you saw with all that lint in it. Now look at how much sticky, gooey, gongy, I do not know what that is, all over the tub itself. How are we going to get a good result when the container itself is not clean? I've often spoken of this before, a very nice published paper that looks at how far things are spread, how much droplet generation and dispersal you get when you're manually cleaning a device. So this is from research published in 2022 by Corey Ofsted, done a lot of work around scopes and in the area of the CSSD. And in this particular study, what they did was they took this purple paper, they pasted it all around the sink, in fact, even on people's PPE in a separate research that she did. And then when water made contact, or water and detergent made contact with the purple paper, it changed color. And if you have a look at the images over there, you can just see how far the droplets were dispersed when cleaning. In this case, they cleaned a colonoscope and a transvaginal ultrasound probe in an area in a CSSD environment. And there you have it. Over 2 meters is the spread when manually cleaning stuff. So where are we cleaning, and what all are we contaminating while we're busy doing that cleaning process, especially if we're in the anteroom or the scrub room for that matter, or in some cases in the operating room itself. In many cases, often between cases, all the reprocessing happens right there next to the patient's bedside. So what all are we contaminating? Are we contaminating the stack itself that the scope is sitting on? Are we contaminating the patient's linen? And of course, this is all often where we perform some of this high-level disinfection. And is that the right place? Don't forget, these are chemistries. Chemistries create vapors. What are we doing to manage the vapors? So let's dive into how we are meant to be using this based on this AORN guideline, the Association of Operating Room Nurses Guideline on Use of HLDs. The first things that popped out of the guideline that reminded me of what I wanted us to focus on were these few points. Remember to follow the manufacturer's instructions for use. Absolutely critical. There are some manufacturers that will state that when you're rinsing the device, you need to rinse it 3 times. Are you doing that? Are you using fresh rinse water? Remembering to test the minimum of the efficacy of the concentration using those test strips. Disassembling the item properly, that you make sure that there's proper contact, cleaning, rinsing, removing visible water. Remember, if there's too much water, if there's debris left on the device, we're never going to disinfect it properly, and too much water is just going to dilute the high-level disinfectant. And of course, immersing, which we've spoken about, but completely submerging that there is full contact. Flushing and filling the lumens. Immersing and making sure that the contact is for the full duration as per the manufacturer's instructions for use. Rinsing off afterwards. And the ARN also states that high-level disinfection needs to be performed in a designated clean area that is separate from where you clean, and it is separate from where the patient care activities are performed. We should be doing this in a controlled area where ventilation is maintained and that there are a minimum of 10 air changes per hour. They also remind us of the documentation, and I'll talk to that in a second now. First, I want to go through some incidences, some published papers where it has gone wrong. So here's one with a 5-year-old child, a 5-month-old child, mind you, that went for a toe probe, or had a toe echo procedure done. What happened at the end of the day was the child suffered widespread damage, including to the lips, the tongues, the pharynx, the tongue, only got one tongue, the pharynx, the esophagus. And all of this was from the probe that hadn't been properly managed. It wasn't properly rinsed after high-level disinfection. The initial symptoms included this black discoloration and the mucosal damage to the child. Follow-up procedures revealed an esophageal stenosis. You can see there 18 days after exposure, they found this fur stuck circumferentially around the child's esophagus. And then the severe stenosis resulted. It took them a year and ongoing dilatation treatment now to manage this child's stenosis. That was really something that was a mistake from the process of the staff. They then, in the summary, in the conclusion and the learning points, they state a few things went wrong when they were doing this procedure. One, they didn't wash properly. That was the very first issue. Secondly, the toe probe was soaked for an extended period of time in the OPA. Was that necessary? And yes, definitely not following the instructions for use. And then there was the fact that a small amount, they say, could potentially, cause damage to skin and mucous membranes. I think that's quite evident with what we see on the child's mouth. Very, very important to rinse off the high-level disinfectant correctly, because you can damage, hurt, burn, damage tissue really, really badly if we don't rinse off the high-level disinfectant. Here's another one that also involves incorrect rinsing. So here, a female patient of 59 years of age had gone for a colonoscopy. She returned 2 days later with symptoms of rectal bleeding and abdominal pain. In fact, 6 to 7 hours after the procedure itself, she was very crampy. She had abdominal pain, which, we would assume might be a little bit common after having a procedure like that. But eventually, 36 hours later, she came back to the hospital because now she had rectal bleeding and severe pain. At the end of the day, she had developed a chemical colitis. And a chemical colitis can happen with whatever type of disinfectant you're using if it hadn't been rinsed off correctly. In this case, it happened to be a glutaraldehyde. Not only does the glutaraldehyde or the high-level disinfectant, whatever its chemistry is, have the potential to damage the tissues and the patient themselves, it has the potential to damage the instrumentation. So just looking at the scope on the right over here, that was some blistering to the surfaces of a scope from concentrated chemistries that hadn't been properly rinsed. But wait, there's more, I'm afraid. Here's another one with an OPA-induced anaphylaxis. So here we have a 25-year-old woman who needed monthly laryngoscopies. The patient had an anaphylactic reaction, as you can see, that included difficulty breathing, a runny nose, urticaria, tachycardia. To now try to understand what the patient was reacting to, they asked for informed consent, and they did a whole series of skin tests to look for allergy testing, and the patient showed a positive reaction to the OPA. Now, OPA has advantages over the old glutaraldehyde that we used to use because it has a higher stability, it's got a better pH range, and it has less levels of evaporation, and therefore, in theory, should lead to less mucosal irritation, especially for the medical staff. That's the theory of it. But in this case, as you see, this particular patient still reacted. Some people do. I've certainly had an incident where we had a patient on the table. We were doing a urology list. The devices were being soaked in an OPA, and the patient actually arrested. It was assumed to be an anaphylactic scenario. The anaesthetist managed to jumpstart and responded quite quickly. We didn't lose the patient. It literally, took us 3 minutes to revive. Patient was fine again, needed to be treated. So anaphylaxis is a potential issue. And of course, staff can also react to these chemistries. Unfortunately, we need to use the chemistries under some circumstances, and therefore we need to use them carefully and we need to use them safely. What does the AORN guideline teach us about wearing of PPE? Choose the PPE based on the degree of anticipated exposure. So that could include a fluid-resistant surgical mask. It could include a face shield or eye protection. I've definitely had a splash in my eye before, and it was not pleasant at all. Fluid-resistant gowns, shoe covers, of course. Having the safety data sheet available is very important. Developing an emergency spill plan and respiratory protection plan for chemicals is also something that's very important. And having some form of eye wash facility or eye wash station, even if it's a receiver with eye wash, with a vial of sterile water or steriles or saline available for an eye rinse close by is very, very important. It's a very important concept. As a theatre sister, we had the incident. I don't know if any of you have ever used formaldehyde, of course, which is an aldehyde-based product. We used to get those really big 4-liter jugs, and we dropped one in the operating room once. It was horrendous. I really didn't have fun for a few hours. As you can imagine, what do you do if you drop something like that? If you are using formaldehyde, do you have a chemical spill kit available? Because those kits often include absorbent materials to absorb the material itself. What do you do if the patient's in the theatre? These are things you need to think about. Have you got a plan for that? Because you're going to need to do something. You need to absorb the spill. Some of the guidelines will talk to whether it's a small spill, less than 5 liters or 200 moles, and the process might change depending on the volume that you're dealing with. Let's say if the spills are over 5 liters, then you need a proper hazmat team to come and clean it up. So ventilating the area, obviously, and treating the people that have been exposed. Very, very important concept. I, in fact, had an exposure yesterday to a biocide that I reacted to. So all of these chemistries over time can become problematic for staff. A point raised here by the ARN here in preparation for high-level disinfection. The high-level disinfectant should be assessed for efficacy, temperature, expiration date, and precipitates or cloudiness. So in this case, of course, they're talking about testing the minimum efficacy using the test strip. They're talking about looking into the container itself and making sure that there are cloudy bits, that it's not, there are no floaters, and that we're using the product within its mix, pour, and expiry dates. Very, very important. And remember to keep the lid on. I know that we go in and out of these tubs all the time, and we need to, but in between uses, please put the lid back on again. Very important to protect yourself and to protect all the staff in the room. So what about record keeping? So they go into quite good detail here about record keeping, and we're going to start with, of course, the logbook. I'm sure many of you have or should have, or hopefully still have, some form of a logbook. In the logbook, often we'll record the date that the solution was opened and the date that the solution expires. So a lot of these products, of course, have a 14-day use or a 21-day use or a 7-day use or whatever it is, depending on the particular product that you're using. And in the logbook, in fact, you should probably also record the expiry date on the bottle itself. So, of course, before you even open it, to pour it into the container is checking the expiry date of the product. Then, once you pour it, you need to say what date did you actually open the stuff and what is the use by date, what is the date 14 days from now. In the logbook, we should record that we have tested it before its use. Did it pass? Did it fail? When did you actually record it? Who did the test? And in some logbooks, they even talk to the temperature. Why? Because when those EN standards I was talking about, all those test methods were done at 20 degrees. So what was the temperature at the time? Because that may affect the efficacy of the product. Labeling the container, of course, is very important. Some of these are extremely difficult to see or read, and in fact, very difficult to know. Maybe somebody puts the only the expiry date, or somebody else only puts the mix date. What are you writing on the container, and how do you know what's in there? So should we not be saying what the product is, because that helps you understand what it is, what you're dealing with, the date that it was poured, the date that it is due to expire from its actual use. But did you check the expiry date of the bottle itself before you poured it in? And what are we recording, and where are we recording all of this information? Then, of course, do you have a logbook for all the devices that were actually done in this? So here the ARN talks to this, and a lot of us are used to having a logbook to record the fact that we tested the minimum efficacy of concentration, but very few people that I know of have got a logbook to document every time we soak something, because that's what we're supposed to do. Like you track and trace your instruments that go through the steam sterilizer, you should be able to track and trace to a degree the items that you're soaking in the high-level disinfectant. So here's what it says in this AORN guideline. So this is the latest version of the guideline on the use of high-level disinfectants. It says over here that you should, of course, record the following. What device it was, which patient it was, the date of the procedure, the location of the use, that you can actually know which bowl and which container it was, that you can identify the container itself. So if you're moving the one from theatre 4 to theatre 3 the whole time, that's problematic. Containers should be dedicated to a particular area so that you know exactly which container you used at each time. The date and time that it was processed, who performed the high-level disinfection, the high-level disinfectant solution type, its concentration, its expiry date, the results of the testing, the temperature, and the exposure time. So that's the extent to which they go to in the American standard. That's the requirement. So I wonder if I ask myself, or we come audit your facility, where would you be at? It's my belief that one of the things I'd like to challenge you to do, to be honest, is to go and establish yourself a quality improvement program today, literally, on your high-level disinfection processes. What are you doing? How are you doing it? How can you improve it? What documentation are you doing? Are you using this effectively? Are you doing it effectively? I've seen some published papers of improvement programs where IPCs were kindly assisted, and maybe that's somebody you could chat to as well to assist you with improving your process. Put together a whole improvement program and plan on how you're using your high-level disinfectant. Audit it. The ARN guideline says that manual high-level disinfection, of course, is performed on semi-critical devices that are unable to undergo sterilization. That's when we use manual high-level disinfection. That's the right time. The steps involved are complex and they require time and attention to detail. We need to manually clean, rinse, and dry and inspect our devices before we put them into the high-level disinfection, because this will help ensure that they are adequately disinfected. The high-level disinfectant solutions must undergo the quality tests we've spoken about, the checks for temperature, the checks for concentration, for volume, for particulates, for cloudiness, for expiration dates before use. And that it's important that we all follow the manufacturer's instructions for use when we're using these products to make sure that the devices are fully exposed to the solution for the recommended contact time. And that's what it takes to use a high-level disinfectant correctly. If you want to master the use of high-level disinfection, follow these principles we've now covered. So bringing us to an end, what have we covered? We've spoken about the terms and the definitions and the standards around high-level disinfectants. We've spoken about Spaulding's classification to make sure that we're putting the right thing in the high-level disinfectant and we're not using it for devices that should be sterilized or can be sterilized. We've spoken about the microbial activity, so you know what they can do and what they can't do. And we've gone through a number of different steps in terms of the correct use. And you clearly, hopefully, have understood that if we do it incorrectly, what the consequences are. We have the potential to harm the patient. You've got a child with fur growing in the throat because why? Because the high-level disinfectant didn't work properly. Then we didn't rinse it properly, and we burnt the child's mouth. Is that the right thing to do? No, we don't mean to make a mistake, I'm sure. But now we know clearly what the guidelines are, what the rules should be. Go and look at your standard operating procedures. Go and look at your systems, audit your systems. Surely we can make some improvements. So thank you for attending today. As normal, everybody will be sent the link to the post-webinar test. If you complete the test, we will certainly send you a certificate of attendance. Hopefully you enjoyed today's presentation. Thank you everybody for joining us.